conference, and then that's where we'll have time for discussion at the end. So good morning, everybody. Thank you for joining. Today, we're really lucky to have a good friend from Poland who is going to talk to us on interventional treatment of paravalvular leaks, how to plan it, the technique and outcomes. And I think this is an area that's really important because often these are patients who are not, good for surgery or are high risk for surgery. And I know you've done many, Wojtek, in Poland, so we'll look forward to learning from your experience. Thank you for joining us this morning.
Thank you very much, Azim. It's indeed a great pleasure to be with you and then share with you some of our experience. So I will talk about the structural interventions involving the paravalvular leaks. So we've been, focusing on the PVL treatment since 2009, and we are a referral center in Poland. It's probably not that there are so many PVLs around, but it's once you start looking for the patients, you have them referred to you. And we work on some new technologies that may improve the PVL closure, including the new dedicated PVL device. And basically our center is a large cardiology center in the south of Poland, very close to the Czech border. We have the students from America and Taiwan since 20 years, and I'm really enjoying work in my center. So coming back to the PVL closure, you know that there are some factors that may contribute to the PVL after the surgical valve replacement. And this is definitely infectious endocarditis, and also some factors related to the quality of tissues around the prosthetic valve. So the heavy calcification, it's one of the key factors related to the PVL, also tissue friability, which may be a sequel of the infectious endocarditis, all other stuff that may end as a PVL, as a complication of the surgery. It seems that the PVL is more frequent after the mitral surgery than after the aortic surgery. Overall, the estimates are roughly 10–12% in some series. Of course, we were not looking for this systemically, and in the centers who have a high volume program for PVL closure, the numbers are high, but it was really underdiagnosed for many years. And in terms of their appearance in time after the surgery, it seems that majority of the PVLs manifest themselves in the first year post-op, and 1/4 of them late. There is a nice expert statement on the endpoint definitions in a similar way to the VARC consortium. So if you are interested, you will find it. So in terms of the treatment, we can either refer the patients for the reduced surgery on transcatheter closure. The reduced surgery is definitely more risky, and many surgeons are not very eager to accept the patients because of the high risk. However, in some cases like valve instability, active infectious endocarditis, or need for other type of surgery, may the surgery only option. On the other hand, there are many patients who are rejected from surgery who have no exclusion criteria, and based on the registries which show that the transcatheter closure reduced the heart failure and hemolysis, this was given an indication in the guideline, and not very strong because there will not be any randomized studies, but to be makes sense. So for heart failure symptoms, I mean, the PVL, it's usually manifested either as a heart failure or or hemolysis or both. And for screening, we usually get the patient with some jet in color Doppler mapping, and there is a lot of debate how to distinguish the severe from non-severe PVL. However, there are some indirect indices, and the more indices of the severity you have, the more likely this PVL is really significant. So for the mitral, it's very often that there is a systolic flow reversal in the pulmonary veins, which abates after the successful treatment, increased pulmonary pressure. In cases, we may expect the reduction of the LA size after the mitral valve replacement. There is none, or there is a progressive dilatation of the left atrium, and there are other also indexes of the severity. For the aortic, it's also hollow diastolic flow reversal, increase of the LV size, LV increased transprosthetic flow, which is more than expected from a given type of and size of this prosthesis. And also we look for the laboratory manifestation of hemolysis. Of course, the diagnosis is purely based on echocardiography in majority of cases, and especially the 3D echo gives you the chance to have the common language between the interventional cardiologist and echocardiographer when you use the standard views we are used to work with. So the location, the size, you can see that there's a large, much difference between these two types of the leaks. Also, the presence of the sutures, because some of the PVLs, which look like one PVL in the Doppler, may be in fact two PVLs because of the surgical sutures left in the middle, and this may impact which occluder we can use. Also, we look for the valve stability. Sometimes the movement of the valves, which looks at the first sight as the instability of the valves, may be a movement of the valve with the surrounding tissue, which sometimes manifests itself like the instability, but in fact it's the movement of the valve with adjacent tissues because of their friability. So it's not always the movement of the valve must highlight the rocking. So it's never something that you can skip, which is the exclusion of active endocarditis. We are very cautious about also because of the endocarditis, especially in patients who are quite early after the surgery. So we are very, very diligent in ruling out endocarditis using either lab or imaging, because the intervention in patients who has unhealed endocarditis can be disastrous. So something that for me it's really crucial is to have the expertise in measurement of the size by the echocardiographer, because the sizing of the plug is crucial to achieve the optimal result. So for both types of the valves, there are some key parameters that you need to know. One is the cross-sectional area, which will allow the proper sizing of the device. Then the length of the channel, in other words, the depth of the leak. Then the maximum and minimum dimensions. So I will just share with you some details on the protocol that we usually do. So this is the protocol which requires the optimal spatial and temporal resolution. So the echocardiographer uses the smallest possible volumes, and this is visualized in single bit zoom 3D volume rate mode with coral Doppler. And the acquired volume is played in multiplanar presentation, and the channel is reoriented until 2 out of 3 of the planes are parallel to the flow. Then the third should be perpendicular at the level of the vena contracta. So then it allows you to estimate all the key features: cross-sectional area, the depth, the maximum and minimum dimensions of the leak, and it has some good reproducibility. So this is how we do the sizing, and it's very much based on the expertise of the echocardiographer. Another examples, it's not always easy because sometimes, especially for some types of the valves, the track of the channel is very tortuous and it's long, and it's really difficult to find the right plane. So in summary, this should be done in multiplanar reconstruction, single bit acquisition only, and probably in your side where you work with the structural interventions, you have your own way of assessment of the PVL. This is how we do it. This is for the sake of some scientific project, but it visualizes how difficult to predict is the track of the PVL. This is the sizing balloon, the special low compliance sizing balloon, which we tried to use. And as you see, the track of the PVL is tortuous, and it's difficult. And this is important because if you put a device, the minimum size of the track will impact on the atrial and ventricular discs in some devices because of the squeezing force of the track. This is the reconstruction based on the CT, and you see how difficult to predict the track of the PVL is. And I will talk about this at the end of the presentation. So aortic PVL, and in the beginning we thought that the aortic PVL it's much easier than the mitral, and our last couple of cases show that sometimes it can be very, very difficult, especially in heavily calcified environment. So for most of the aortic PVL, we use mother and a child technique, which includes 6 French regular coronary guide catheter with 125 centimeters, 5 French coronary diagnostic catheter. And depending on the location of the leak, you can either use the Amplatz left plus Judkins right inside, or we try to modify, we just cut the end of the diagnostic catheter, of the 5 French catheter, to make the shorter band, because if we use the right, it sometimes diverts the wire from the track. So sometimes it's useful to either strengthen the diagnostic catheter or cut the very end of this. Sometimes for the other location like non-coronary or right, you can use the MP plus Judkins right, or you can use Amplatz 2. So after the passage of the wire, you can either use Terumo or we use a coronary wire. You push inside the ventricle the 5 French catheter. You exchange for exchange length guide wire, either Steve or just regular diagnostic wire, and then put the 6 French catheter inside. After that, you decide. For a single plug, you can use the 6 French catheter to deliver the AVP3. And for multiple plugs or for larger plugs, you exchange over the wire, over the 300 or 260 wire for the vascular sheath, like the Q sheath, which can start at 6 French, and you can use up to 8-9 French if you need, and of course if the track of the PVL permits. For the mitral PVL, it's more complicated because you need to account for the transeptal puncture, which has to be located in a way that allows you proper access to the leak. And also in this part of the procedure, the echocardiography, it's really invaluable. So this is the surgical view, and of course the location of the stick will differ if you have the PVL located close to the left atrium appendage, and then you may use medial and low stick, and it will be different for PVLs located close to the septum, where you need the higher stick. So of course there are different techniques like transeptal techniques and retrograde techniques from the aorta, and of course transapical. Transapical is very easy, and if the surgeon is very experienced in having good transapical access, this procedure it's much faster, easier, especially for posteromedial leaks. But in our hands, we almost never use it after we started to use the combo technique. So in some books and in some recommendations, this was a division between the leaks which are easy to access from the transeptal puncture, and some of the locations were deemed to be for retrograde or apical access. However, I think that once you start doing more and more procedure, you will have your own ways, and majority of cases can be closed using the transeptal puncture. So how the combo technique looks like. So actually it will use an approach which is similar to having a very good backup, like the one you have to when you do the mitral clip. So we started to use the large sheaths, starting from Agilis, which has some limitation. The 8.5 French, it's too low profile to have multiple plugs. But then we changed to the larger sheets like 12 and 14 French. And then this gives you a good stability over the PVL and easiness of exchange of any type of the catheters once you achieve it. So this technique, it's in our hands the preferable ones for the mitral PVLs, and it's really very effective. And once you are above the leak, regardless of the location, you just need to have a 5 French diagnostic catheter with some wire. Sometimes you don't even use the wire, because for the large leak you can be guided by the echo, and you can cross with the 5 French catheter into the ventricle. And it's really giving you a stable position and excellent freedom of exchanging the gear. And then you can use either single or triple delivery sheaths when you use the large size catheter. So the one from Medtronic we use, it's the one that's usually used by electrophysiologists for the cryoablation. In Europe, there is an Occlutech sheath, with the 14 French sheath, which is deflectable, as you see. and it's really easy to use for the PVL closure. So this is example of the FlexCat with the diagnostic catheter inside and the occlutic sheath. So this is a case example of the relatively large PVL. So after the passage of the wire and the diagnostic catheter, what you can do is you can have a safety wire across, which allows you to recross easily when you misplace your plug and you need to repeat the procedure. And the second wire over which you can either deploy the large delivery sheath or diagnostic catheter or angioplastic catheter in case of the single plug. Also, what you can do is you can leave a soft wire in the atrium, which will help you to achieve some distance between the tip of the large sheath and the PVL, because sometimes it's very close to the atrial portion of the leak. And once you start deploying the plug and pulling back your delivery sheath, it may get even closer. And then once you start to withdraw it to have some distance to open the atrial disc, you may lose your position. However, if you leave the soft wire in the atrium, you can have some space, which will make the withdrawal of the delivery sheath easier. This is an example of the PLD device being deployed. It's being pulled, and the safety wire in the atrium provides some distance. And also for this type of the device, it's very important to have the echocardiographer, which will precisely tell you when the ventricular portion of the device is properly located. And so the opening of the atrial portion is guided by the position of the ventricular portion on the other side, confirmed by the echo. So this example showed that you can have your plug open, being withdrawn, and at the same time you can keep your safety wire in the to guide you back once you lose your position. And this is the plug which is deployed. So we've done a small registry showing that the use of the combo technique may significantly reduce the implantation time and technical success rate when it's used versus diagnostic catheters. So since we started to do this combo technique, we almost never used the retrograde access to the mitral valve, or very, very rarely we ask the surgeon to open the apex. Then the current device selection, I fully understand it's probably different than in Europe and in the US. So we're using AVP3 and PLD devices. So the PLD devices is CE marked for PVL, and since I think September, the AVP3 from Abbott is also approved in Europe for PVL closure. So it's called now a valvular plug. And AVP4, it's used most commonly for the PVLs related to the TAVI. So these two types of devices, they have less in common than I would think at the beginning. So the AVP is a nitinol mesh, and it has no sealing fabric inside. On the other hand, the PLD device, it has two layers of the sealing fabric in the discs. Then none of the devices can have controlled orientation. If you put inside the ventricle the the AVP, you are not really able to control, to torque the delivery wire to change the orientation. Our approach is sometimes to put out all the plugs inside the ventricle and allow to them to be self-reoriented by, adhering to the ventricular tissues. They sometimes they just reorient themselves in order to have better orientation. For the PLD, it's the mounting on the delivery cable. It's like a ball and the bioptome. So it's not really easy to twist the device. And even if you twist the delivery cable, it doesn't translate one-to-one into the orientation of the plug. So this plug has two markers, which allow you, when you look in the fluoro, to see how is it oriented versus your defect. So if you see the separation of the two dots, you can have some information if they are approaching the PVL, towards this short or long axis of the plug. And there are two types of the PLD device. There are rectangular and square. And also in terms of the middle module, there are two types. There are waist and twist. So you can imagine they are designed for two different type of the defects. So in order to close the PVL with the vascular plug, you need to put several of them in order to achieve the oversize of at least 30–40%. So you just fill the defect with the nitinol mesh, and you let it thrombose, or you let it heal and stop the flow. In case of the PLD, you cannot do it, because as you see, if you oversize the middle module by stretching it, if you put this plug into the PVL, which is too longer, I would say, than 5–6 millimeters, it starts to stretch. This is the properly deployed device. And this one has elongation of the middle module, which produces the dog boning of the discs. And if you remember this slide, the sealing is in the discs. So if this looks like this, if it starts to dog bone, then it's not opposing against the entry and the exit of the defect, and you may have the leak through the occluder. So this type of the device is very nice for relatively large PVLs, but with the depth of no more than 5–6 millimeters. And also, it's probably better for round and oval defects. So also, what you need to consider is the relation to the moving discs of the prosthetic valve. So you need to choose your device based on the risk of impingement of the prosthetic valve. So either you use multiplug approach with the PLD. Usually it takes between 2, 3, 4 devices to seal a leak which is larger than 0.3, and this achieves you the good sealing of the PVL, or you use the PLD device, like in this case, with the same result. So you see that especially for the PLD, the proper sizing using the echo it's really crucial. So this is also confirmed by our registry, showing that if the oversize is achieved with the AVP, it's okay. But if the oversize is achieved with the PLD, it may produce the improper sealing of the leak. What about the hemolysis? We did a registry on looking in particular for on the topic of hemolysis, and we found out that really the hemolytic anemia is more likely to be related to the mitral PVL and also to the PVL with heavy calcifications. If you look at the two groups of patients based on their baseline LDH activity, they differ only in terms of the location, preferring the mitral and calcified PVLs. And what we found is that in order to achieve the reduction of hemolysis, you need to achieve at least 90% sealing of the cross-sectional area. Of course, the numbers are not very huge, but it gives you some signal. Then, if you close the PVL, you want to achieve as much of the reduction of the flow through the channel as possible. Also, what I would say is that in some cases, the reduction of the flow through the significant leak may unmask some smaller leaks which are not hemodynamically significant, but they start to produce hemolysis. So probably around 10% of patients, even 15% of patients, after the closure of significant in terms of hemodynamics defect, may have either recurrent or worsening hemolysis. So this is something that needs to be addressed further. And of course, evaluation of the procedural success, it's based on the echo. And one of the few things that are consistent is that the successful closure of the mitral PVL reduced or reversed the flow reversal in the pulmonary veins. You need to be prepared for some complications. They are not very frequent, but sometimes you can have dislocation of the discs, so you need to have snares and large deflectable sheets, which will allow evacuation of the embolized plaques. But it doesn't happen really often. And again, in terms of the future perspective, I try to explain why both types of the devices have limitation in terms of the sizing and in terms of their capacity to be overexpanded. And sometimes it's very difficult to predict the track and the length of the channel, and you end up with a device which is dog boning and not working really well. So there are complex anatomies, especially long, tortuous, and calcified tracks, which are really difficult to seal. The cases when you implant the plug and you do not achieve the complete sealing, like in cases when there was a surgical suture left across part of the leak, which was not recognized. And you have some risk of interference with the mechanical valve. It's relatively difficult to have orientation of the rectangular devices to be predictable. So this is something for the future. And also residual hemolysis, I think it's something that has to be considered. We did a clinical registry with assessment of distribution and sizes and anatomies of patients. And we did a prototype of the device, which was based on the, in our opinion, unmet clinical needs. And we came up with a device which looked like this. It's a triple disc device, and it has a sealing fabric inside all 3 discs. So even if you stretch the middle module, it has a sealing, and even if there is some dog boning of the distal parts, it allows for a better sealing than the one that's with only 2 layers of the sealing fabric in the discs. So this prototype was produced in different sizes, and it's quite easy for this company we work with to produce the patient-tailored devices, sometimes very long, sometimes very to approach the crescent-shaped long PVLs. And this device was tested in Alize pathology in Canada with some good results in terms of the biocompatibility, and it will enter the clinical study somewhere next year. So to conclude, the clinical presentation is heart failure, hemolysis, and endocarditis has to be ruled out. The transcatheter closure of PVL is preferred treatment for patients with heart failure and hemolytic anemia, with the exception of patients who have infectious endocarditis and instability of the valve. In majority of cases, multiple plugs are necessary to seal the leak. The combo approach with the large deflectable sheaths improves the mitral PVL management. There is some optimal toolbox with delivery sheaths, guide wires, snares, catheters, which has to be on board. This procedure is very dependent on the excellent transesophageal echo imaging. We need to check up the patients after the closure because there may be some residual or recurrent hemolysis, and we need to address this. And incomplete closure, even if it reduces the heart failure symptoms, may impact the hemolysis. At the end, I would like to invite you to get in touch with me if you need anything, if you want to discuss or get some reprints of our publications. We also published a book dedicated to the transcatheter treatment of the PVL, and I can send you the PDF of the book if you are interested. Please let me know. And for last 5 years, we were having a meeting in Katowice, which was dedicated to imaging in intervention. It included 2 days PVL expert meetings. And you can see this year it was online, of course, but it included people from different countries like Japan, like France, like Spain, Greece, Turkey, people who work with the PVL. And it's also possibility to have hands-on experience. So if the COVID permits next year, it will be in person. If not, it will be online. So you are kindly invited to join us next year. Thank you very much.
Thank you. Thank you, Wojtek. That was incredible. It was a really great talk, and I think it's nice to hear one of these talks from someone who has, and a group who has so much experience in the field. I'm going to ask one of our fellows to join up as well. Manaf, if you can put your video and sound on to help us with the questions. Before he addresses the questions, I want to make sure that I understand your technique, this combo technique, Wojtek. So you have a large steerable sheath, right? And inside it, you have a diagnostic catheter plus your wire to cross the leak. You cross with the wire, you then get your diagnostic catheter across, okay? Then you put your stiff wire, whichever stiff wire you prefer, okay? You pull out the diagnostic catheter, okay? And then what do you use to deliver the device? What catheter do you use? Do you use a sheath or a large guiding catheter?
Okay. If you want to implant simultaneously 2 AVP3, then you can use 2 parallel coronary guide catheters.
Okay.
And it's easy. So you need to put the guide sheath, then to put 2 wires, take it out, and to put 2 sheaths, and you are in. And sometimes you can.
Catheters, so you put 1 guide catheter on each wire.
Yeah. And then in such way you can have also 3 sheets into the large guide. So then you can deploy 2, 3 AVPs simultaneously, and you open each one at the same time, but you use 3 or 2 different coronary guide catheters.
Yeah.
If you want to use 3 or 4 AVPs at the same time, you can also use large vascular sheath like Cook sheath, 9 French, for example, or 8 French, depending on the size of the defect, and you can you can do it using the 1 sheath. For the PLD, you need a delivery sheath, not the guide catheter. So the technique is the same, and the choice of the device and the choice of the delivery sheath depends not only on the sizing, but also on how easy it is to cross, because sometimes it's so difficult to pass through the calcified PVL, even 6 French catheter, then probably it's better to have the stiff wire and to push 1 braided vascular delivery sheath.
Okay.
So this is dependent on the size and the number of the plugs you want to implant.
Right. I in my own practice, I've preferred using long sheaths rather than guiding catheters, just because the sheath has a dilator. It's sometimes, it's easier. The transition to get across has been easier. So what I've been doing is, I'll put like an 18 French dry seal in the vein when I'm doing a mitral, so that I can have multiple devices in or multiple sheaths in without bleeding. I didn't know, once again, in America, we are very backward compared to you in Europe. I say this after having had all the wonderful devices in the past, but we don't have AVP3. We don't have, obviously, the Occlutech MLD device. I also like the big Occlutech sheath, which I think is going to be very useful to give you that support, because sometimes I think the big challenge is, even though you have a stiff wire, you don't have the support to push your delivery sheath across, and so having the steerable sheath gives you that support.
Yeah, I think you made excellent point. I only recently started to use the dry seal, and this is excellent device. Yeah, I mean, it's something that really can be tailored depending on your preference, but well, direction is it's the same. You have the better support in the atrium, and this deflectable sheath can have a lot of freedom of movement. So the echocardiographer tells you, you need to direct anterior or posterior in the same way like for the mitral clip, and it's very easy. Once you are above the track, then you just go with the wire.
Yeah, no, I think it's phenomenal, the difference that 3D TE has made to these procedures. I remember when we first started doing these procedures years ago with our 3D TE, a PVL would be a 4-5 hour procedure, right? Now, because of 3D TE, I mean, you cross in 10-15 minutes usually. Yeah.
Yeah, for me, a challenge is a long calcified and tortuous track, because it's so difficult. You sometimes see something like this also for the TAVI related PVL. It's so difficult to cross with the 5 French catheter.
I'm going to ask you about that in a moment, but I'm going to let Manaf, who's one of our interventional fellows, maybe ask you a few questions. Go ahead, Manaf.
Sure. Thank you very much for this talk. It's something we don't see that much PVL closure, so it's very nice to see your approach and the devices that are available. Dr. Latib, I don't know if it's because I was added late or what, but I don't see any questions in the chat or Q&A, but I have a few of my own.
Yeah.
So
just one from Dr. Taub, which I'll ask, and then you can carry on. So
sure.
there's a question from Dr. Taub, who's the head of ECHO here in our institution, and she said the EROA changes during the cardiac cycle. So how do you choose the timing of measurement? Okay, and do you choose the largest EROA for sizing? And what's the acceptable frame rate for color 3D?
Well, yeah, that's very important. So we use the maximum size during the maximum flow, okay. And especially in friable tissue, it may make some difference. Also, it's important to notice that sometimes for the screening, the patients may have transesophageal echo in the left lateral position, supine position, and then if they are on the table and they're on the back, the PVL may look different because of the transition of the valve. So the last question is for the maximum.
Yeah. So that was, I think you answered. You choose the largest EROA in respect of the timing. And what's the acceptable frame rate for color 3D?
Well, what's the this I need to check in a second, but yeah, this is something I can't answer right now. But this is single bit reconstruction.
Right. Yeah, because she mentioned, she always asks the difficult questions to us interventionists. She mentioned that your images showed 18 to 22 as the frame rate. So Cynthia, maybe you can help us because we're just interventionists. Do you think that's acceptable, or is there a better frame rate? So apparently it could be better. And what would you suggest as the best frame rate? The higher, the better. There you go.
Okay. That's something that's really, I was so happy when I learned how to look on the echo instead on the fluoro, and I keep on learning the echo all the time. Yeah, thank you.
Absolutely. I mean, we wouldn't be able to do these procedures without our echo partners. So, Manaf, please go ahead.
Sure. So I get one concern that I've heard about is especially in this friable type tissue subsets, when you are attempting to close a paravalvular leak, is that you may just end up opening a new paravalvular leak next to it, and by placing more and more plugs, you can essentially sort of unzip. So my question is there a way to predict in which leaks that this may happen, and if you encounter this kind of issue, do you have any particular approach or treatment algorithm?
Well, I think, yeah, this is a very important remark. It's possible that you can expand the leak either by rupturing of the sutures that are across the leak. Probably for the friable tissue and like compliant tissue, it's difficult to say if you really make the leak larger or you just expand something that was already there, because this friable tissue can move and the spatial relation can change. I don't remember a case where we created a leak that required surgery. In some cases, we ruptured the suture and we had to implant additional plugs. But what you said is very true, and you need to follow up the patients, because sometimes it's not always a single leak. It's not always two evident leaks. Sometimes you have some smaller defects. And once you close the most significant defect, after a month, you may see something new that was not there before, because this one was the dominant one. So the answer is yes. You can create larger leak, especially in environment where you have sutures or friable tissue, or friable tissue plus calcification. And the second thing is that you need to follow the patient, because some trivial leaks that were recognized at the time of the procedure may become more significant and also produce hemolysis later on.
Right. That was actually going to be my follow-up question, is how you monitor patients after closure? Is there
so Manav, maybe I'll add to that.
Sure.
It's always also important, in these cases, if you're able to find the original op note, okay, and look at the original op note. Majority of surgeons will do interrupted sutures when they put a mitral valve in, but there are occasionally cases where they've done a continuous suture, okay? And knowing that can be important, because the ones that can get larger are the ones with a continuous suture rather than an interrupted suture. So I think it's always worthwhile going back, trying to find the op note, speaking to one of your surgical colleagues and just making sure there's nothing unusual about the surgery that you need to know about beforehand.
That makes sense.
Go ahead.
Thank you. Yeah, my follow-up question was just about patient follow-up afterwards, and how often you see these new leaks come up.
Okay, so our routine is to ask the patients for 30-day transthoracic echo. In case anything seems wrong or their LDH is increasing, we do the transesophageal echo. And I would say that probably around 10%, 10 to 15% can have worsening of the regurgitation. And
compared to the procedure.
Yeah. And also, we need to remember that something that created the environment leading to creation of PVL was not really treated by the procedure. So if there is a poor tissue quality, even if you close the leak and after 6 months the patient is fine, the same poor quality tissue it's maintained. So new PVL can emerge after a year. So of course this is something that needs to be considered.
We had a case last year that we put in 3 plugs, large leak, amazing result. No residual PVL, and then 6 months later, the leak in the same area had gotten bigger. And I think it goes back to sometimes you just can't predict the amount of friable tissue that there is in that area.
That's true. Yeah.
Manav?
Great. Thank you. I don't think I personally have any more questions.
I have a couple more. And I really wanted to hear what your approach was with TAVR PVLs. My approach has generally been, particularly if it's a self-expandable valve, to see if I can put a balloon expandable valve inside to get rid of the PVL. But I wondered, but they're not all cases I like that, where you can, the PVL could be because of a big chunk of LVOT calcification, and another valve is not going to make it better. So I just wondered what your approach was to the TAVR PVLs.
Yeah. So we do CT, angio-CT routinely, and sometimes it shows you the nature of the leak, because if the nature of the leak is a tract that's along the highly calcified tissue, probably post-dilation would not solve it. Maybe the implantation of the second valve, but not always. So we try to address the PVL first to consider the valve in valve. If it's not possible, we try to use either AVP3 or AVP4. But my experience, we don't have that much experience in TAVI related PVL. But my experience was that it was something very difficult in some cases, mainly due to the fact that we are not able to pass with the delivery catheter.
Sure.
After we did this on second attempt, we were successful, but crossing of the PVL may be very difficult.
Yeah, I agree. I think particularly if you have a tall frame such as a self-expandable valve, yeah, it can be extremely challenging. And then I had one other question, a last question, just because I'm seeing a patient now and I've not had to do one of these before, so I wanted your advice. So I got referred a patient who has a peri-ring leak, okay, who has a mitral ring with a large leak of about, involving maybe 45-degree quadrant area. Any thoughts on what you experienced? Have you had any experience with rings and leaks?
Yeah. We did one tricuspid and one mitral, and it was successful. However, I think it was a little bit less than 45%. But if this is mitral.
Mitral, yeah. Well, not 45%, but 45 degrees of the
circumference. Okay.
Less than 90.
And this is the full ring.
Yeah, full ring.
Full ring. Well, I think if you can close it with based on the echo sizing, it's probably worth trying, because even if the patient has to be escalated to the surgery, it doesn't add a lot of risk. But only 2 cases I can remember. It was successfully closed with good result. But it's also challenging. But if you don't risk, you don't risk the leaflet motion. The question is what plug would you choose? If it's 45 degrees, it's probably the crescent shape.
Yeah.
So
I don't have many. We don't have many choices in the US. It's either AVP2 or it's AVP2.
Yeah. Well, yeah. So I would try it. It's if it's full ring. And
I mean, the only other one I've done like this was also had a problem with stenosis. So I did a valve and ring plus the leak, and that worked really well. But this one is just the leak. It's not, there's, the valve gradients and so on are quite low. I'll let you know how it goes when I do it.
Good luck. Okay. I'm sure you can do it.
It's so good seeing you. Thank you for taking the time today to spend an hour with us. We really appreciate it, and we learned so much from you again, my friend.
My pleasure. Thank you so much.
Stay well and stay healthy in Poland. Please.
Stay safe and hopefully see you soon.
Okay.